Welcome back to Applied Pharmacokinetics and Pharmacogenomics. In today's session, we'll be discussing aminoglycosides and vancomycin in adults. In comparison to the textbook, we will not be discussing the following in my lectures. No special populations aside from intermittent hemodialysis patients. We won't be addressing any of the following nomograms, nor Bayesian PK computer programs. In addition, the following will be slightly different from that listed in the textbook. Target concentrations for vancomycin aminoglycosides. Intravenous bolus single-dose equation will be used for loading dose or for hemodialysis dosing. Intermittent IV infusion steady-state equations will be used for maintenance dose and dosing from serum concentrations. T prime, which is infusion time, will be set at 1 gram per hour for vancomycin and 0.5 hours for aminoglycosides. The equations for clearance, Ke and V, are listed. For vancomycin, dose will be rounded to the nearest 250 milligrams, and for aminoglycoside, dose will be rounded to the nearest 20 milligrams. Lastly, we will not be doing any loading dose for aminoglycoside. Vancomycin and aminoglycoside equations are really the same for non-AUC dosing. And for simplicity, a one-compartment model is used for dosage calculation. What differs between the two are drug-specific Ke and V coefficients. This is a very typical concentration versus time graph of a medication, in this instance of an antimicrobial. The red line represents the minimum inhibitory concentration, which is the lowest concentration to inhibit visible bacterial growth. Peak concentration is denoted by Cmax, trough concentration denoted by Cminimum. PAE stands for post-antibiotic effect. T represents a time period in which a concentration is above the MIC of the organism. Antibiotic, in terms of efficacy, are loosely categorized into these three categories. Some drugs display the best efficacy with a maximized Cmax to MIC target, while others a time above MIC target. And the last category is area under the curve, AUC over MIC target, which predicts efficacy. In today's lecture, I will be introducing you to vancomycin, its pharmacokinetic and pharmacodynamic parameters, introducing you to aminoglycoside and its PK/PD parameters, discuss dosing methods and clinical therapeutic drug monitoring, including general principles, initial dosage determination, when to check serum concentrations, use of serum concentrations to alter subsequent dosages, dosing in intermittent hemodialysis patients, and describing monitoring parameters when dosing these medications. First, vancomycin. It is a glycopeptide antibiotic which inhibits bacterial cell wall synthesis. It has activity against gram-positive organisms, including staphylococcus, such as MSSA or MRSA, Streptococcus, Enterococcus, and Corynebacterium. Vancomycin can cause ototoxicity anywhere between 1 to 9%, and typically that's associated with very high serum concentrations above 80 micrograms per ml. This rate may be overrepresented due to earlier drug impurities, poor documentation of cause and effect, and concurrent ototoxins. Unfortunately, this side effect can be permanent. Nephrotoxicity is generally rare with vancomycin monotherapy. The rates described varies according to study and depending on the definition of nephrotoxicity. Traditionally, with trough-based dosing, it's anywhere from 5 to 15%. The risk increases with concurrent nephrotoxic agents, critical illness, longer duration of therapy, elevated vancomycin Cminimum of greater than 20, elevated vancomycin area under the curve of greater than 600, when patients are receiving at least 4 grams or more per day of vancomycin, and in patients with chronic kidney disease. Other adverse events associated with vancomycin include red man syndrome. This is an infusion-related reaction, so typically institutions limit the infusion rate of vanco to 1 gram per hour. Neutropenia, phlebitis, drug fever, anaphylaxis, and headache also can be seen with vancomycin. Vancomycin PK/PD parameters. Vancomycin displays linear kinetics, meaning serum concentration changes proportionally with dosing. So doubling the dose will double the serum concentration. The drug is poorly orally absorbed, but is widely distributed throughout the body and follows a 2-3 compartment pharmacokinetic model, with an alpha phase for distribution, followed by the elimination phase, and then finally a tissue release phase. It is minimally metabolized, with clearance over 90% eliminated as unchanged drug through glomerular filtration. And for simplicity of drug dosing, we typically equate clearance of vancomycin to creatinine clearance as estimated by the Cough-Cough-Gall equation. This is true except when we're doing AUC dosing, which I'll explain later. The half-life of vancomycin in a typical adult without renal insufficiency is anywhere from 6 to 8 hours. Area under the curve, AUC over MIC ratio, is the best predictor of vancomycin efficacy. The drug displays minimum post-antibiotic effect and is slowly bactericidal. Now let's move on to vancomycin dosing. Traditionally, vancomycin has been dosed for many years to target a C minimum of 15 to 20 for serious infections. This requires checking C minimum and altering dose by proportion. C minimum served as a surrogate for AUC. However, AUC-based dosing is now recommended by the new 2020 National Vancomycin Dosing Guidelines, which is reviewed and endorsed by the American Society of Health System Pharmacists, the Infectious Diseases Society of America, the Pediatric Infectious Diseases Society, and the Society of Infectious Diseases Pharmacists. The reference is in the footnote. When dosing to target AUC, we dose to an AUC of 400 to 600. This is assuming the MIC of the organism is less or equal to 1 micrograms per ml. This has been associated with improved clinical outcomes, including higher clinical cure rates and lower mortality. Further, when targeting AUC, many patients may require lower than traditional C minimums and therefore less aggressive dosing, so there's toxicity benefit as well. In general, dosing to target AUC requires 2 serum concentrations to adjust subsequent dosing. There are computer programs which can use one level, but we will not be talking about Bayesian computer dosing programs for my lectures. Now switching gears to aminoglycosides. These are the currently intravenous available products in the U.S. Tobramycin, amikacin, plazomycin, gentamicin, and streptomycin. Aminoglycosides are bactericidal, and they inhibit bacterial protein synthesis at the 30S ribosome. In general, their usages are the following: either for gram-negative treatment, such as urinary tract infections, double empiric gram-negative coverage in septic shock patients, or for multi-drug resistant gram-negative infections. For these indications, tobramycin, amikacin, gentamicin, or plazomycin may be preferentially used. For gram-positive synergy, such as streptococcal or enterococcal or Staph aureus endocarditis, gentamicin or streptomycin usually are used, and then amikacin and streptomycin can also have mycobacterial activity. Aminoglycoside also can cause ototoxicity with an incidence of approximately 2 to 5%. This is related to the AUC or high C minimum of the drug. It's unfortunately generally irreversible, and the risk increases with concurrent ototoxic agents. It can manifest as either auditory toxicity with tinnitus, high-frequency hearing loss, or vestibular toxicity, such as loss of balance and oscillating vision. Nephrotoxicity caused by aminoglycoside use is approximately around 10% and caused by accumulation in renal cortical cells of the proximal tubule. It is related to the AUC, rarely occurs in the first 3 days, and monitoring is difficult because oftentimes BU and creatinine may lag behind several days following tubular injury. Fortunately, this is generally reversible if not caught too late. Aminoglycosides can also cause neuromuscular blockade, and generally no allergies have truly been reported with aminoglycosides. Aminoglycosides, too, display linear kinetics in which serum drug concentration changes proportionally with dosing. It has poor oral absorption, and its volume distribution V is similar to extracellular fluid content of the body. It follows a 3-compartment pharmacokinetic model, distributes very poorly into the CSF, and partial partitions into fat. Aminoglycoside is also highly renally cleared, over 90% unchanged by glomerular filtration, so for simplicity in daily dosing calculations, we equate aminoglycoside clearance to creatinine clearance as estimated by the Cockcroft-Gault equation. Aminoglycosides have a half-life of approximately 2 to 3 hours in adults with normal renal function. It displays concentration-dependent killing with improved clinical response, seen with Cmax to MIC ratio of 10 to 1. Maximum killing is achieved at 20 to 30 times above the MIC. However, clinically, we can never target dosing this high due to toxicity. Aminoglycosides display post-antibiotic effect, a period of persistent suppression of bacterial growth even when the drug concentration falls below the MIC of the organism. Traditionally, aminoglycosides have been dosed to target Cmax to MIC ratios. However, there's more literature now emerging to suggest that AUC to MIC ratio may be a more reliable indicator of bacterial killing, with AUC-MIC ratio of 30 to 50 as the target in non-critically ill patients with low burden infections, and targeting an AUC to MIC ratio of 80 to 100 in critically ill patients with high burden infections. However, this is currently not mainstream for the majority of aminoglycosides on the U.S. market. Therefore, for the purpose of our lectures, we will only be looking at dosing to target Cmax to MIC ratio and not for AUC. We will also not talk about plazomicin. When dosing to target Cmax to MIC ratio, we can either do conventional dosing, where the target is 4 to 1, or high peak extended interval dosing, where the Cmax to MIC ratio target is 10 to 1. The conventional method is preferred for infections where the Cmax doesn't have to be so high, for example, UTI or gram-positive synergy. And by dosing lower, we're exposing patients to less drug and therefore less toxicity. On the other hand, there are other infections, such as non-UTI systemic gram-negative infections, where we do need a higher Cmax to kill the bacteria. And so the higher Cmax provides optimal activity, and extending the dosing interval allows the patient to clear the drug. It also takes advantage of the post-antibiotic effect. When performing conventional dosing and the organism MIC is not available, we should be dosing to target the following Cmax and Cminimum. For pyelonephritis, gentamicin or tobramycin Cmax should be between 8 to 12 micrograms per ml. For amikacin, between 30 to 35. When treating cystitis, the gentamicin-tobramycin Cmax should be between 3 to 5, or for amikacin, between 15 to 20. The Cminimum for gentamicin-tobramycin should be less than 1 for non-dialysis patients, or less than 2 for dialysis patients, and this is a post-dialysis level. For amikacin, Cminimum should be less than 4 for non-dialysis, or less than 8 as a post-dialysis level. When dosing for gram-positive synergy, this applies to gentamicin only. The target Cmax is 3 to 5, with a Cminimum of less than 1 or less than 2 post-dialysis. When performing high peak extended interval dosing and the organism MIC is not available, for all gram-negative infections except cystitis, gentamicin and tobramycin Cmax should be between 18 to 22, and we should be dosing to target a Cmax of 60 to 80 for amikacin. Cminimum for gentamicin tobramycin is defined as undetectable, which is less than 0.25 for non-dialysis or less than 2 as a post-dialysis level, or for amikacin, less than 1 for non-dialysis patients or less than 8 as a post-dialysis level. When the organism MICs become available, then we can target our Cmax based on a desired Cmax to MIC ratio. So for conventional dosing, as you recall, our Cmax to MIC ratio is 4 to 1. So if the organism MIC, for example, is 0.5, then we target to dose to a Cmax of 2, because a 2 to 0.5 ratio gives you that 4 to 1 ratio. On the other hand, if we're doing high peak extended interval dosing, our Cmax to MIC ratio is a 10 to 1. So therefore, with the same MIC of 0.5, to achieve a 10 to 1 ratio, our desired Cmax has to be 5. Now moving on, how do we determine initial dosage for vancomycin and aminoglycoside? There are nomograms out there which can help with initial dosage determination, which won't be part of my lecture. The pharmacokinetic dosing method is what I will be focusing on, and this is most clinically used because it allows for individualized target serum concentrations to be chosen, as well as customizable PK parameters. For the course, you will be provided an equation sheet, and all the equations I will be using are on the equation sheet. In clinical practice, for intravenous bolus, we use the single-dose equation for vancomycin loading dose, and for both vancomycin and aminoglycoside dialysis dosing. For intermittent intravenous infusion, steady-state equations are used for maintenance dose calculations and dosing by concentrations. Note that AUC dosing equations are for vancomycin only. And these clinically used equations are the equations highlighted in red on the equation sheet. In clinical practice, we generally do not use continuous infusion, extravascular, or average steady-state equations. Therefore, I won't be talking about these in my lectures. When trying to come up with an initial dosage for vancomycin or aminoglycoside, there are several steps involved. Step 1 is to obtain baseline data. At many institutions, pharmacists are formally consulted to provide dosages for vancomycin or aminoglycosides. It's always important that before we go into dosing, we first evaluate the appropriateness of antibiotics. This requires collecting some pertinent data, including indication for antibiotic, age and appropriate measurements, such as weight and height, allergies, past medical histories and comorbid conditions, pertinent lab values, and presence of risk factors for nephrotoxicity and or ototoxicity. Once it is determined that the antibiotic is appropriate for the patient indication, we need to calculate a few weights. This is step 2. When given a total body weight and height, we can then calculate patient's ideal body weight. For males, this is 50 plus 2.3 times the inches above 5 feet. For females, this is 45 plus 2.3 multiplied by the inches over 5 feet. Adjusted body weight needs to be calculated if the patient's total body weight exceeds at least 30% of the patient's ideal body weight. Adjusted body weight equals to ideal body weight plus 0.4 multiplied by the difference between total body weight minus ideal body weight. Step 3 is to estimate the volume of distribution V in liters using population-derived equations. For vancomycin, V is equal to 0.65 times ideal body weight. For aminoglycoside, V is equal to 0.3 times total body weight unless the patient's adjusted body weight is at least 30% above ideal body weight. In that case, we will be using adjusted body weight. The V coefficient, 0.65 for vanco or 0.3 for aminoglycoside, can be adjusted depending on patient population as well as the disease state the patient has. However, for the purpose of our lecture, we will be sticking with these numbers. Step 4 involves determining a dosing method and desired steady-state concentrations. For aminoglycoside, we need to decide whether we're going to do high-peak extended interval dosing or conventional dosing, therefore its respective target concentrations. No, in general, institutions do not use AUC dosing for aminoglycosides. For vancomycin, the Cmax typically used in calculations is 30 to 40 micrograms per ml. If targeting C-minimum only, the typical C-minimum target to use for dosing is 15 to 20 micrograms per ml. If targeting AUC, that target is generally 400 to 600, but we still have to use the C-minimum in our calculations, and that C-minimum ranges from 10 to 20. So potentially, as you can see, when we're targeting AUC, the C-minimum range is lower than that we're targeting C-minimum only. So potentially the daily dose may be lower since we're targeting a lower C-minimum. If we're dosing to AUC, some of the later calculation steps for this will be different than if targeting C-minimum only. Step 5 is to calculate a loading dose. Loading dose is more commonly used for vancomycin. It should be considered for patients with creatinine clearance less than 60, especially for a serious infection or if the patient is critically ill. It's to load an empty tank, so it allows for achievement of therapeutic concentrations quicker than without using a loading dose. This is provided that the subsequent maintenance doses are appropriate. Loading dose is equal to V times desired Cmax. Step 6 is to estimate the patient's creatinine clearance using the Cockcroft-Gault equation, which is equal to 140 minus H times ideal body weight over 72 times serum creatinine, multiplied by 0.85 for females. Note, if the patient's total body weight is less than ideal body weight, we should be using total body weight. Use adjusted body weight if the patient's total body weight is at least 30% above their ideal body weight. Step 7 is to estimate the elimination rate constant, Ke. This is the fraction of V cleared per unit time. We use the following population-derived equations. For vancomycin, Ke equals to 0.0016 times creatinine clearance. For aminoglycoside, Ke equals to 0.003 times creatinine clearance plus 0.01. We can also estimate Ke using a basic pK equation, which is clearance in liter per hour all over V. Step 8 is to estimate the patient's half-life for the drug. This is the time that it takes to have a 50% reduction in the serum concentration. Half-life is related to the Ke, elimination rate constant, by the equation 0.693 over Ke. Although half-life is not a variable used in any of our subsequent equations, many times pharmacists still like to know the half-life estimated for the patient to give them a sense of how quickly the patient may clear the drug. So now, beginning with step 9, the calculation steps differ if we're dosing to target Cmax and Cminimum versus AUC. Remember, AUC dosing is for vancomycin only. Let's go through targeting Cmax and Cminimum, so vancomycin non-AUC dosing or aminoglycoside dosing, which is the same equations. Step 9, estimating a dosing interval tau. The unit for tau is in hours, and in clinical practice, we usually round it to a practical number. Tau is equal to ln of Cmax steady state concentration minus ln of Cminimum steady state concentration all over Ke plus T prime. T prime stands for infusion time in hours. We're going to be standardizing what T prime is for my lecture. T prime for Vanco is 1 hour per gram. So with a dosage of 750 to 1000 milligrams, infusion time is 1 hour. For 1250 to 1500 milligrams, infusion time is 1.4 hours. And for 1750 to 2000 milligrams, infusion time is 2 hours. On the other hand, for aminoglycoside, infusion time is always 0.5 hours regardless of dose. Step 10 is to estimate the initial maintenance dose using this equation, K0. Note this equation is red, so this equation is important, and there are many equations derived from this. K0 is the infusion rate. It's equal to dose over infusion time, which is in turn equal to C max at steady state times Ke times V multiplied by 1 minus e to the exponent of negative Ke times tau, which is the dosing interval, all over 1 minus e to the exponent of negative Ke times T prime, which is infusion time. If we isolate for dose by moving T prime over, then we will have this second equation. Remember, for aminoglycoside, dose is always rounded to the nearest 20 milligrams, and for vancomycin, dose is always rounded to the nearest 250 milligrams. Step 11 is to predict a Cmax and Cminimum from a regimen. This is because often we need to round the dose and/or a dosing interval for convenience reasons. After rounding, we would like to know what actual Cmax and Cminimum we can expect from that regimen. So the Cmax equation is listed here for you. And from there, the second equation is the equation for predicting Cminimum. As you can see, there are two new variables in this equation, Tminimum and Tmaximum. Tminimum is the time at which Cminimum happens. It is at the end of the dosing interval. For example, if this is an 8-hour regimen, then the Tminimum occurs at 8 hours from the previous dose. Tmax, on the other hand, is time at which maximum concentration happens, but this is defined as 0.5 hours post the end of infusion. So if the infusion takes 0.5 hours, like for aminoglycoside, then Tmax is at 0.5 hours post another 0.5 hours to account for the end of infusion. What if now we're trying to target AUC? Remember, this is for vancomycin only. Then we need to go back to step 9. Remember, AUC represents the area under the concentration time curve for an entire 24-hour dosage period. So for every 8-hour regimens, AUC represents 3 doses. For Q48-hour regimen, AUC represents half of this dosing interval. Target vancomycin AUC of 400 to 600 with a C minimum of 10 to 20. Step number 9 is the last step in which the equation is the same for either targeting Vanco-AUC or for C minimum dosing used for Vanco or aminoglycoside. So this is the same slide as before for tau. Step 10 now is different when dosing to target AUC. It is to estimate a total daily dose, which is the dose required to achieve target AUC, and this is the only time in class where we'll be using the Vanco-specific clearance instead of approximating Vanco clearance with creatinine clearance. Clearance is in liters per hour here, versus creatinine clearance is generally in milliliters per minute, is equal to Ke times V. Total daily dose then is equal to clearance times desired AUC. Step 10 continued, estimating the individual dose. So remember, AUC represents the whole 24 hours. So dose is equal to total daily dose times tau over 24. That will give you the individual dose per dosing interval. Step 11. Predict Cmax and Cminimum from a regimen that has been rounded. To predict Cmax, use this equation and then subsequently Cminimum. Remember, T minimum is the time at which Cminimum happens, which is at the end of the dosing interval, and Tmax is the time at which Cmaximum happens, which is 0.5 hours after the end of infusion. This is a graph of area under the 24-hour curve. As you can see, it is made up of two trapezoids, a blue one, which is the area under the curve during infusion period, and an orange one, which is the AUC for the elimination phase. Step 11 continued to predict the AUC from a regimen that's been rounded. So we've predicted Cmax and Cminimum. What is the AUC we may get from this rounded regimen? So use a linear trapezoidal rule to calculate the two different trapezoids and then sum them together. So AUC of the infusion period, as listed here, of the elimination period, as listed here, and then sum the above areas together, multiplied by the number of doses per 24 hours gives you the total 24-hour AUC. Now we're going to go through some dosing examples so we can illustrate everything we've just talked about. This is an example using tobramycin, so therefore it has to be to target trough dosing, Cminimum dosing, and not AUC dosing. JM is a 60-year-old 80-kilo height 69-inch male from a nursing home. Now in ICU with gram-negative pneumonia. Susceptibilities are pending, so we don't have an MIC. His creatinine is 1.1 and is stable. Come up with an empiric tobramycin regimen for this patient. Now use the steps outlined previously for targeting Cminimum dosing to calculate this patient's parameters. Step 1 is to obtain baseline data. Step 2, calculate ideal body weight. In this case, patient does not qualify for adjusted body weight calculation. Step 3, calculate aminoglycoside V. 4, we need to determine what dosing to use. Since we're treating a gram-negative pneumonia, we think high peak extended interval dosing is appropriate. So with that, we need to target a Cmax of 18 to 22 and a Cminimum of less than 0.25. Now in clinical practice, we can't just use a range, so therefore we have to use a fixed number. So let's use Cmax of 20 and Cminimum of 0.2. In your exams as well, I will specify exactly which Cmax and Cminimum targets we should be using. Step 5, no loading dose for aminoglycosides. Step 6, estimating creatinine clearance. Step 7, calculating aminoglycoside Ke using the creatinine clearance. And then step 8, estimating a half-life. And although this isn't even going to be used in the subsequent equations, a 3.1 hour half-life tells us the patient will clear the drug within 24 hours. So step 9 involves calculating the dosing interval. So because we're coming up with the initial dose, the Cmax steady state concentration and Cminimum concentration are our desired concentration. So 20 and 0.2. Infusion time, remember, for aminoglycoside is always 0.5. So the tau we estimate would be 21.15 hours, In clinical practice, we would round that to 24 hours. If this was a vancomycin case, when we're estimating a new tau, you must kind of guess what infusion time to start with, because remember, for vancomycin, infusion time varies according to the dose. Usually start with an infusion time of 1. And once we figure out dose and subsequent equations, you may have to go back and recalculate tau and dose using the right infusion time that corresponds to the dose. For exams, I'll make sure that all the calculations are very black and white. Step 10, calculate a dose. We use the equation K0, which is infusion rate. Okay, so for this, we plug in all the numbers. So again, desired maximum concentration of 20, our previously estimated Ke, estimated V. Okay, this is drug dosing interval, the dosing interval we just calculated in the previous slide. And then on the bottom, T prime is 0.45 hours for infusion time. And remember, K0 stands for dose over infusion time. So subsequently, to isolate for dose, we need to multiply this above equation by the dosing infusion time, which is 0.5. So we come up with a dose of 504 milligrams, which we will round to 500 milligrams. So the rounded regimen for this patient is tolvamycin 500 milligrams IV every 24 hours. And because we had done some rounding, we'd like to know what this rounded regimen will provide us in terms of Cmax and Cminimum. So step 11 is to plug all the numbers back in to come up with a predicted Cmax with this regimen, in which in this case is 19.8, okay, and Cminimum is 0.12. And so in order to calculate the Cminimum, as you can see, Tminimum represents the time at which Cminimum happens. In this case, it's a 24-hour regimen, so time at which minimum concentration happens is hour 24 from the previous dose. Tmax is 0.5 hours after the end of infusion. Aminoglycoside infusion is 0.5 hours. So half an hour after that means an hour after. Okay, so 24 minus 1 is the time difference here. A different example using vancomycin. JM is a 43-year-old, 80-kilo, 69-inch male being started on vancomycin and cefepime for ventilator-associated pneumonia. His creatinine is 1 and is stable. Calculated loading dose and empiric vanco regimen for the patient. Again, going through all the steps. Step 1, obtain baseline data. Step 2, calculate ideal body weight. Step 3, calculate V. Step 4, determine target Cmax and Cminimum. In this case, I've chosen to be 35 for Cmax and 18 for Cminimum. Step 5, calculate loading dose. Okay, and the loading dose is desired Cmax, which is 35 times the estimated V. And so the loading dose is 1593, which we will round to 1500 milligrams. Step 3, calculate creatinine clearance. Step 7, calculate Ke. And step 8, estimate half-life. Step 9 is estimate dosing interval tau. So in this case, we empirically put an infusion time of 1 for 1 hour. Okay, and our dosing interval comes out to 6. Step 10, estimate the dose. Again, using this K0 equation in red. So this is again a key equation that in which some of the subsequent equations are derived from. So for dose in this case, so our desired Cmax is 35, Ke, estimated V, okay, remember we have to take infusion time over, so times infusion time of 1 hour, multiply by the rest of these parameters. And we come up with a dose of 1018 milligrams, which we will round to 1000 milligrams. Because of some rounding, now we will use our regimen to predict what it will bring for us in terms of Cmax and Cminimum. So Cmax will be calculated using this equation and will be 34.4 with a regimen of 1000 milligrams every 6 hours, and Cminimum will be 17.5. Remember, these are still all initial estimates for a patient because we really don't know from patient levels whether our estimates for creatinine or for V are even true. So this is initial regimen. Now what if we want to target AUC? So go through the steps for targeting AUC. The last common step was step 8. For step 9, it's the same equation but a different target Cminimum or dosing to target AUC. We'll target an AUC of 500, same Cmax of 35, but our range for C minimum is anywhere from 10 to 20. So let's choose a C minimum of 12.5. So step 9, okay, for this, we will come up, using the same equation, we'll come up with a dosing interval of approximately 8 hours. Step 10, targeting AUC, estimating the total daily dose required to achieve this target AUC. Okay, remember, this is the only time we'll be using vancomycin specific clearance instead of cramping clearance. So clearance in liters per hour is equal to Ke times V. So in this case, clearance is equal to 6.83 liters, which will feed into the total daily dose equation. Multiplied by the desired AUC of 500 will give us a total daily dose of 3413 milligrams. Step 10, continue estimating a dose. Once we have the total daily dose, we can calculate what is the per interval dose by the following equation. Dose is equal to 3413 times the dosing interval of 8 hours all over 24. And that means per dose we should be giving around 1138 milligrams, which we will round to 1250 milligrams. With this rounded regimen of 1250 milligrams every 8 hours, we like to predict what Cmax, C minimum, and AUC this provides. So the equations are the same as before. However, please note the C minimum calculation here. In this case, T minimum, okay, the time at which minimum concentration happens, is at hour 8, since we're in an 8-hour dosing interval. But Tmax, remember, occurs at 0.5 hours after the end of infusion. And because the 1250 milligram dose for vancomycin will be infused over 1.5 hours, Tmax occurs at 0.5 hours after the end of 1.5 hours. So Tmax occurs at hour 2. So that's why this time difference here is 8 minus 2, which is 6 hours. Now we would estimate what the dosing regimen provides in terms of AUC. Remember, we have to add together the two trapezoids representing area under a curve during the infusion period and elimination period. This is represented by the first two red equations. Then the third red equation will add together the top two. And so the AUC for a 24-hour dosing period is 529, which is within our AUC target range of 400 to 600. The difference between targeting C minimum only versus targeting AUC for this patient, as you can see, the same patient, if we're targeting AUC, our regimen is 1,000 milligrams every 6 hours. Our total daily dose is 4 grams, which provides us with a Cmax of 34.4 and a C minimum of 17.5. If we're targeting AUC, our regimen is slightly less aggressive, at 1250 milligrams q8 hours, with a total daily dose of 3.7 grams, but still providing us a therapeutic AUC of 529, Cmax of 35.2, and a C minimum of 14.3. Now, not every patient will have a different regimen when using the two different dosing approaches, dosing to target C minimum or AUC. However, some of the patients will have a lower daily dose of targeting AUC. Therefore, in these patients, they will theoretically have a decreased toxicity risk. Now, when do we check serum concentrations after starting the initial regimens? For vancomycin, when checking initial concentration, if we're targeting only C minimum, check concentration on steady state unless we're concerned about accumulation earlier. If dosing to target AUC, we can check two concentrations either after the first dose in patients at risk for nephrotoxicity or at steady state. For the purpose of this lecture, assumed concentrations are always checked at steady state, so we can use intermittent intravenous infusion steady state equations. When checking a single C minimum for vancomycin, draw within 30 minutes prior to the end of the dosing interval. Remember, the end of dosing interval is not determined by when the next dose starts, but rather when the previous dose was given. If obtaining two concentrations, the first concentration should be drawn at approximately 2 hours following the completion of infusion. So we will minimize drawing a level too early when the drug is still distributing. The second level should be drawn at least one estimated half-life after the first, to avoid being too close to the first level. For aminoglycoside, if we're doing conventional dosing, obtain concentrations at steady state. we can obtain actual maximum and minimum concentrations, defined as the following. So infusion time is 0.5 hours. Cmax again is at 0.5 hours after the end of a 0.5 hour infusion. Cminimum is at the end of the dosing interval. Please note that these are not the recommended draw times for high peak extended interval dosing. For that, we would obtain 2 random concentrations after the first dose, because patients do not achieve steady-state concentrations. The infusion time is equal to 0.5 hours again. Draw the first concentration 2 to 4 hours post the end of infusion, and the second concentration at 10 to 14 hours post the end of infusion. Oftentimes, however, in real life, 2 concentrations aren't obtained at the desired times when we dictate them, because nurses can be busy and patients may not always be available at the time we want them to be. So, concentrations are often obtained at random. If so, we need to use these random concentrations to extrapolate to the true Cmax and Cminimum, defined as the following times. Okay, the same as we said before, Cmax 0.5 hours after the end of infusion, and Cminimum is the concentration at the end of a dosing interval. So how do we use these serum concentrations to adjust dosages so they are customized to the patient? There are different ways to do this. We won't be talking about the linear PK method or the PK concepts method. We will be touching upon the trough-only method for vancomycin, and then for both, the same method, just different names. For vanco, it's called the one-compartment model parameter method, and for aminoglycoside, the Salchak-Zaske method. The trough-only method for vanco uses a proportional equation, dose 1 over C1 equals the dose 2 over C2. For this, it does require a steady-state Cminimum and maintaining the same dosing interval and using this ratio to adjust dosage. Can only be used if we're dosing to target Cminimum and not targeting AUC. So example of this, ZW is a patient on vanco for the treatment of MRSA bacteremia, creatinine of 1.1 and stable. Vanco 1000 mg Q12 hours was administered. A steady state, a Cmax was obtained and equals to 10 micrograms per ml. Calculate a new dose that would provide a steady state Cminimum of 15. So in this case, using this ratio, 1000 mg gave us a C concentration 1 of 10. What dose gives us concentration of 15? So by proportion, D2 is equal to 1500 milligrams. So therefore, our new regimen would be vancomycin 1500 milligrams every 12 hours. The one-compartment model parameter method, or the Salchak-Zaske method, is superior in that it uses 2 concentrations to determine whether a regimen targets the appropriate Cmax, Cminimum, AUC, and to alter dosages. It does not rely on having a real Cmax or Cminimum, as long as the 2 concentrations are at least 1 estimated half-life apart, so we can minimize the effect of assay error on the calculations. If the levels are not obtained at steady state, then they have to be after the same dose. If at steady state, the 2 concentrations can be after different doses, because the concentration can always be extrapolated to any dose. So this method uses any 2 concentrations on the same line to extrapolate to Cmax and Cminimum. Step 1 is to determine time of dose and concentrations. In real life, that requires looking up the electronic medical record to see when doses are given and when concentrations are obtained. Step 2 is to calculate the patient's real KE. This is the patient's true elimination rate constant because it relies on patient's actual concentrations, C1 and C2. T1 and T2 are time points that correspond to when the C1 and C2 are obtained. Step 3 is to calculate the patient's half-life. Step 4, if one of the concentration is the actual Cmax, then you can calculate patient's V directly because you have the Cmax concentration using the following equation. So in this case, Cmax is actual Cmax, K0 refers to a patient's infusion rate, T prime is infusion time, that's the small t, and capital T is the dosing interval. However, often in real life, only 2 random concentrations are available, rather than one of them being a true Cmax. Rather, step 4 often involves the extrapolation of the patient's true Cmax and Cminimum from 2 random concentrations C1 and C2 using the equation in red on the left, which can be arranged into the two equations on the right by substituting C1 with Cmax and C2 with Cminimum. The time points reflect the time points in which concentrations are obtained. T2 represents when C2 is obtained, Tmax represents when Cmax is obtained, which is usually at 0.5 hours after the end of infusion. Tminimum is at the end of dosing interval, and T1 is when C1 is obtained. If the patient's actual Cmax and Cminimum is within your desired target concentrations, you no longer have to go any further because you know that the patient's regimen is fine and you can keep on giving the patient the same regimen. But what if the patient's Cmax and Cminimum fall outside your desired range? Then we need to proceed to the next step. Step 5 is to calculate the patient's actual V. I say actual because we're no longer using desired Cmax in this equation, but rather the patient's true Cmax, as well as true KE. Step 6, we need to use the patient's actual KE and desired Cmax and Cminimum to calculate a new tau. Why are we using desired Cmax and Cminimum again? Remember, the patient's current regimen is providing the patient with a Cmax and Cminimum not within our desired range. So in order to hit the desired range, we need to come up with a new regimen. But this time around, we're going to be using the patient's actual KE. Step 7, use the patient's actual KE and V and desired Cmax to calculate a new dose. So in this case, Cmax is desired, KE is actual that we've derived earlier, and V is actual. Step 8, using the new regimen, which often involves rounding a dose and/or dosing interval, we'd like to know what actual Cmax and Cminimum it will provide. So, inserting all the variables we have into these two equations, including the patient's actual V and KE, we will come up with the patient's Cmax and Cminimum with this regimen. Remember, for the Cminimum equation, Tminimum occurs at the end of the dosing interval, while Tmax is at 0.5 hours after the end of infusion, which is 0.5 hours for aminoglycoside, but for Vanco varies by dose. An example to illustrate what we just talked about. KE is a 70 kilogram male receiving tobramycin 600 milligrams every 24 hours for the impaired treatment of gram-negative pneumonia. His last dose was at 10 a.m. A post-dose concentration drawn at 14 p.m. equals to 18.2, and a second concentration drawn at 21:30 p.m. equals to 3.8. So again, we have C1 and C2 as well as the time of which they were drawn, which is T1 and T2. So KE is equal to minus ln of 18.2 minus ln of 3.8. The time difference between the two, T1 occurred at 1400 and T2 occurred at 2300. That's a time difference of 7.5 hours. That gives us a KE of 0.209. With that KE, now we estimate the patient's half-life to be 3.3. Again, half-life isn't used in dosing calculations, but gives the pharmacist an impression of the patient's true clearance of a drug. Step 4, since neither concentration is a true Cmax, therefore we must extrapolate to true Cmax and Cminimum in order to find out whether they're within desired range, and whether we should keep or change the current regimen. Recall the dosing regimen: 600 milligrams every 24 hours, dose at 10 a.m., first level at 1400 is 18.2, second level at 2130 is 3.8, the actual calculated KE is 0.209. Remember, extrapolated Cmax is defined as 0.5 hours after the end of infusion, and infusion time for aminoglycoside is always 0.5 hours. So now we plug in the equations. So the equation for Cmax is 3.8, okay, so that's concentration 2, over e to the exponent of negative Ke, with the time difference between concentration 2, which occurred at 21:30, and Tmax, which occurred at half an hour after the end of infusion. So, if the dose was given at 10 a.m. and took half an hour to infuse, and Tmax occurred half an hour after that, then Tmax occurred at 1100. So the time difference between T2 and Tmax is 10.5 hours. So Cmax is equal to 34.1, And then on the right side, C minimum is equal to C1, which is 18.2 times e to the negative exponent ke 0.209 times the time difference between T minimum, which is at the end of dosing interval. So T minimum occurs in this case at 24 hours, so the next day at 10 a.m., and T1. T1 is at 1400. So time difference between those two levels is 20 hours. So C minimum is 0.28. Because in the previous slide, the Cmax and C minimum are not within desired range, therefore we need to proceed further with our calculations in order to derive at a better dosing regimen. Step 5, calculating the patient's actual V, this time using the patient's known Ke and Cmax. So if we plug in all the numbers with dose over infusion time, that's K naught, Ke is 0.209, T prime infusion time is 0.5 hours, again, all over Ke, times the patient's actual Cmax of 34.1, multiplied by 1 minus e to the negative Ke 0.209, times the patient's regimen's dosing interval, which is 24 hours, we derive that the patient's actual volume distribution is 16.82 liters. Next, we need to come up with a new dosing interval for a patient's new regimen. To do that, we'd like to target for our desired Cmax and C minimum, but this time using the patient's actual Ke, which is 0.2009. And so with that, the patient's new dosing interval is 22.5, rounded to 24 hours. So step 7 is to calculate the patient's dose using the K naught infusion rate equation. Using the patient's desired Cmax concentration. Again, we're using desired Cmax rather than the real Cmax because we're trying to aim for this with the new dose, but using the patient's specific Ke and Vd. So K naught is 704 milligrams over 0.5 hours. So the dose is equal to 704 times 0.5, which is 352 milligrams, rounded up to 360 milligrams. Now we have a rounded regimen of 360 milligrams every 24 hours. We'd like to know what true Cmax and C minimum we would expect with this. Again, we would be using the patient's actual V, Ke, this new regimen of 360 milligrams infused over 0.5 hours and a dosing interval of 24 hours. We find that our Cmax that we expect from this regimen to be 20.46 and C minimum of 0.17. which is within our desired range. An example using vancomycin. Ke is a 70 kilogram male receiving vancomycin 1500 milligrams q12 hours for the treatment of MRSA vascular graft infection. Target Cmax 30 to 40 and C minimum of 15 to 20. His last dose was at 10 a.m. A post-dose concentration drawn at 1400 p.m. equals to 30, and a second concentration drawn at 20:30 p.m. equals to 16. Please note here that this regimen is every 12 hours and no longer every 24 hours. But fortunately in this case, both levels were drawn post the same dose, which was given at 10 a.m. So step 2, to calculate the patient's actual Ke, we have concentration 1 of 30, concentration 2 of 16. The time difference between the two concentrations, which is 6.5 hours, gives us a Ke of 0.0967. Step 3, with this Ke, we have patient's half-life calculated, which is 7.2 hours. Step 4, since neither concentration is a true Cmax, therefore we must extrapolate to true Cmax and C minimum to see whether they're within target range. If they are, we don't have to proceed further, and the patient can continue on the current regimen. If they're not within target, though, we have to calculate a better regimen for the patient. Recall the vancomycin regimen is 1500 milligrams every 12 hours with a dose given last at 10 a.m. Level 1 occurred at 1400 p.m. is equal to 30. Level 2 at 2030 is equal to 16. The patient's actual Ke is 0.0967, which we just calculated. So on the left side is the equation for C2 equals to Cmax times e to negative Ke with the time difference multiplier. This translated to where we isolate Cmax equals to 16, okay, that's the level 2, over e to the minus patient's actual KE times the time difference between T2 and Tmax. In this case, T2 occurred at 20:30. However, Tmax is 0.5 hours after the end of infusion. Being that the dose is 1500 milligrams, the infusion time is 1.5 hours. So half an hour after a 1.5 hour infusion makes Tmax occur at 2 hours after the starting time, which is 10 a.m. So Tmax occurs at 12 noon. So time difference between 12 noon and 20:30 p.m. is 8.5 hours. That gives us a Cmax of 36.4. On the right side, we try to calculate the patient's true C minimum with this regimen, using C1, which is 30, times e to the negative patient's actual KE of 0.0967 and a time difference here. T minimum is at the end of dosing interval. In this case, we have a Q12-hour regimen. So 12 hours from when the dose is given, so dose was given at 10 a.m., 12 hours after that would be 2200, minus time at which level 1 happened, which is 1400. So time difference between those two concentrations is 8 hours. So C minimum is 13.84. Because in the previous slide, we saw that the patient's true Cmax and C minimum are not within target range. Therefore, we need to proceed further with calculations in order to derive a better regimen for the patient. So step 5, we need to find out the patient's actual V using the patient's true KE and Cmax. So dose of 1500, infusion time of 1.5, okay, all over patient's actual KE, true Cmax, gives us a volume distribution of 55.87 liters. Step 6, with this information, we'd like to target now a desired Cmax and C minimum and come up with a new dosing interval. So this new dosing interval uses desired Cmax of 35, desired C minimum 18, patient's true KE, infusion time of 1 hour, and gives us approximately 8-hour dosing interval. Step 7 is to calculate the new dose using the K0, the infusion rate equation. In this case, we have to use desired Cmax because we're trying to target with this new regimen the desired Cmax. However, using the patient's actual KE and V, so we're customizing the dose to the patient's own PK parameters. K0 is 1105, so new dose is 1105 times infusion time of 1 hour. Okay, so that will give us an approximate dose of 1000 milligrams. Why infusion time of 1 hour? So typically with Vanco, we start with 1. Sometimes when we come up with a higher dose, we might have to go back and adjust this infusion time. Step 8, we have a rounded regimen now. Okay, we need to validate this new regimen in the sense that we need to know what is the true Cmax and C minimum we come up with this regimen. Are they still within target despite our rounding? So we plug in all the numbers, okay, including the patient's actual, right, V and KE, and we come up that the patient's Cmax with this regimen is predicted to be 31.68 and C minimum of 14.78, which is close to within our target range. So this is an okay regimen. So the previous two examples are when the two concentrations are drawn after the same dose. But what if two concentrations are drawn after different doses, which do happen not infrequently in real life? So an example of how to do this. KE is a 70 kilogram male receiving tobramycin 620 milligrams every 24 hours for the empiric treatment of gram-negative pneumonia. His last dose was at 10 a.m. on day 1. A post-dose concentration drawn at day 1 at 1400 is equal to 18.2. A second concentration was ordered on day 1 for 2130, but this was not obtained. Next day, the pharmacist reorders a second concentration on day 2 at 21:30 p.m., which comes back as 4.68. On this day, though, however, the dose was given a slightly different time, at 1100 a.m. To depict what we have to do on a graph, tobramycin dose on day 1 is given at 10 a.m. Concentration 1 is obtained at 1400 p.m. and is equal to 18.2. The next dose, okay, which was given at 1100 a.m., so slight different timing than the previous day. Day 2 concentration was drawn at 21:30 p.m. and comes back as 4.68. So on the second day slope, C2 occurred at 10.5 hours post the dose. We now must extrapolate C2 back to the first dose curve. So what would be 10.5 hours after the dose on the first day? If the dose now is given at 10 a.m., then 10.5 hours after that dose means if the level comes to the first curve, it would occur at 20:30 p.m. So when can we use two concentrations drawn after two different doses together to calculate the patient's true PK parameters? We can only do this at steady state, when the elimination curve is the same from dose to dose. So a concentration at the exact post-dose time on the elimination curve should be the same from dose to dose. Now let's go back to step 7 to complete the steps for AUC dosing. Remember, this is for vancomycin only. If targeting AUC, use the patient's actual KE and V to calculate vanco's specific clearance in a subsequent maintenance dose using the following equations. First, clearance. Clearance for this is vanco clearance, not creatinine clearance, in liters per hour equals the KE times V. Total daily dose is equal to clearance times desired AUC, and dose, which is the per interval dose, is total daily dose times tau over 24. Step 8. Because often doses are rounded, therefore we want to know exactly what the Cmax and Cminimum would be with this rounded regimen. So we insert the numbers we have for actual patient V and KE into these equations. Step 8. We also like to know what this rounded regimen will provide in terms of AUC. So use the linear trapezoidal rule to calculate AUC during the infusion period, then subsequently during the elimination period, and finally by summing them up and multiply by the number of doses for 24 hours to give us the 24-hour AUC. Moving on, we will talk about vancomycin and aminoglycoside dosing in intermittent hemodialysis patients. Graphically, this is what dosages and concentrations will look like for patients receiving vancomycin and aminoglycosides who are end-stage renal disease on intermittent hemodialysis. Following initial dose, we will achieve a Cmax, followed by a shallow elimination curve. This usually is due to some residual renal clearance and non-renal clearance. And then on the day that they receive hemodialysis, which generally occur either Monday, Wednesday, Friday, or patients may be on a Tuesday, Thursday, Saturday dialysis schedule, post-dialysis, the patient concentration will drop because of dialysis removal. Then we will give a supplemental dosing to achieve the target Cmax again. Typically, when we check levels for dialysis patients, we check a pre-dialysis level and then extrapolate what their post-dialysis level will be based on how many hours of dialysis removal they will receive. So how much is removed by dialysis? For both vancomycin or aminoglycoside, we can do daily estimation. Typically, we assume about 10% per hour of hemodialysis when high flux filters are used, and typically high flux filters are used these days, as well as 10% non-renal clearance per day. So for a patient, their current concentration is equal to their Cmax, what they started off with, times 90% is left to the exponent of number of days that they have for non-renal clearance. Okay, so if they have 1 day of non-renal clearance, then we assume 10% non-renal clearance, and therefore 0.9% of this concentration is left, multiplied by 0.9 to the exponent of number of hours of hemodialysis. So if there's 1 hour of hemodialysis, that means 10% removal, so therefore 90% or 0.9 of the initial concentration is left. When to check levels. A pre-dialysis concentration should be checked after a maintenance dose and prior to hemodialysis. Based on assumed percent of removal per hemodialysis session, we can then approximate a post-dialysis concentration. Why not just check post-dialysis levels? Why do we check pre-dialysis? Because it has advantages. It's easier to obtain concentration prior to dialysis. since dialysis schedules can often be unpredictable. And it also avoids us inappropriately drawing a post-dialysis level too early, still within the post-rebound period. So anytime patient is post-dialysis, immediately post-dialysis, their blood concentration will fluctuate as the drug moves from the central compartment back into the tissues. If we were to draw the level too early, we could potentially get a falsely elevated drug level. How to come up with the initial dose for somebody on intermittent hemodialysis. For vancomycin, hemodialysis targets are Cmax of 25 to 30. This approximates a pre-dialysis level of 20 to 25. For aminoglycoside hemodialysis targets, the Cmax are the same as in non-dialysis patients. Cminimum are slightly different. The dosing equation we use is dose equal to Cmax of steady state times estimated V. So an example, on Monday, for a patient who is ideal body weight 70 kg, targeting a Cmax of 25, the estimated V will be 0.65 times ideal body weight equals to 45.5 liter. Dose will be equal to Cmax desired times this V, which is equal to desired Cmax of 25 times 45.5. This gives us a rounded dose of 1250 milligrams to give the patient as an initial vancomycin dose. To estimate the first maintenance dose, we need to estimate how much of the initial dose will be left after non-renal clearance and a session of hemodialysis. So the same example continued. Recall the patient received 1250 milligrams of vancomycin on Monday, and the patient's V is 45.5. On Wednesday, the patient received 4 hours of hemodialysis. So what is the patient's current concentration after this? Starting off with a Cmax of 25, multiplied by 0.9, so 90% is left, to the exponent of number of days of non-renal clearance, in this case is 2, multiplied by 0.9 and get 90% left for every hour of after every hour of dialysis, so to the exponent of number of hours of dialysis, gives us 13.29. So after 2 days of non-renal elimination and 4 hours of hemodialysis, we estimate that the patient will have 13.29 micrograms per ml of vancomycin in their system. Now we'd like the patient to go back to a level of 25. So using the same equation as before, we calculate a maintenance dose. Dose is equal to desired Cmax times V. In this case though, we no longer are dosing from 0. Patient already has 13.29 in their body, so we are only dosing to target of 25 minus this quantity that's already in the patient's body, times the V. So the patient really needs 533 milligrams, which we can round to 500 milligrams, post this hemodialysis session on Wednesday. Calculate subsequent dose based on concentration. Example continued. So we're targeting a Cmax still of 25. Monday, the patient got 1250 milligrams. On Wednesday, the patient received 4 hours of dialysis. In the previous slide, we calculated the patient should receive 500 milligrams post the dialysis to maintain the Cmax of 25. On Friday, we checked the pre-dialysis level, and the level came back 15. Subsequently, the patient also received 4 hours of hemodialysis on Friday. We need to come up with a subsequent maintenance dose by proportion. So to do this, we need to extrapolate backwards from our pre-dialysis concentration of 15, extrapolate back to C maximum by adding the non-renal clearance for the 2 days, which we say is about 10% per day. So C max is equal to 15, the pre-dialysis concentration, times 10% added back for non-renal clearance for 2 days, 1.12 exponent of 2, which gives us a Cmax of 18.2. So 500 milligram maintenance dose gave us a Cmax of 18.2. What dose will give us a Cmax of 25? Now the proportion equation, D1 over D2 is equal to C1 over C2. So we determined that a dosage of approximately 750 milligrams will provide us with a desired concentration of 25. So we've dose adjusted based on the patient's actual concentration. From here on, assuming if the patient's hemodialysis schedule doesn't change and maintains, let's say, Monday, Wednesday, Friday, then after every hemodialysis, and assuming they get the same number of hours of dialysis as this time, they should only require 750 milligrams. Of course, if the patient's hemodialysis schedule or number of hemodialysis hours per session changes, then the non-renal clearance or hemodialysis removal needs to be accounted for. For vancomycin, redosing occurs typically post each hemodialysis session. To estimate an initial dose for aminoglycosides, the target Cmax for aminoglycoside dosing in dialysis patients do not differ than those who are non-dialysis. Cminimum are slightly different. Dose is equal to Cmax desired times estimated V. Example of this, total body weight for a patient is 70 kilos. We're targeting for a gram-negative infection, therefore we want to do high peak extended interval dosing with Cmax of 18 to 22. Let's say we want a Cmax of 20. Estimate V is 0.3 times total body weight in this case, which is equal to 21. And then the patient's total dose would be dose equals to 20 times 21 or 420 milligrams. To calculate a subsequent maintenance dose, we need to estimate how much of the initial dose is left after non-renal clearance and hemodialysis. So recall the patient received 420 milligrams of tobramycin on Monday with an estimated V of 21 liters. Then on Wednesday, patient receives 4 hours of hemodialysis. Assuming 2 days of non-renal clearance, we estimate then the patient's concentration remaining post-dialysis will be equal to what the patient started off with, so 20, times 90% remaining after each day of non-renal clearance, so 0.9 to the exponent of 2, times 90% remaining for each hour of dialysis, so to the exponent of 4 hours of dialysis. So we know that at the end of dialysis, we estimate the patient will have a concentration left of 10.63 micrograms per ml. For tobramycin, due to toxicity reasons, we will not always be dosing to the Cmax after every dialysis. We, in fact, do not need to redose, as you recall from a much earlier slide, until the post-dialysis concentration is less than 2. Typically, a pharmacist will check a pre-dialysis aminoglycoside level when they anticipate that the patient may require redosing after that hemodialysis. They ballpark this by knowing what Cmax they start with, how many days of non-renal clearance, how many hours of dialysis. So assuming that the patient had a maintenance dose of 420 milligrams on Monday after hemodialysis, then subsequently receives 4 hours of dialysis each on Wednesday, Friday, and Monday that follows. The following Wednesday, a pre-dialysis level was checked, and it was 2.3, followed by another 4 hours of dialysis. So we estimate that the concentration post-dialysis will be equal to 2.3 times 0.9, which reflects 90% remaining, to the exponent of 4 hours of dialysis, equal to 1.51. This level now is below the 2, which is indication for us to redose. We need to redose to a Cmax of 20. So dose is equal to desired Cmax times V. In this case, we need to minus the 1.51 that the patient still has in their system. So the dose we come up with is 388 milligrams, which we round to 380 milligrams to be given post that hemodialysis session on Wednesday. Due to ototoxicity concerns, aminoglycosides are rarely used for gram-negative infections with high peak dosing in hemodialysis patients because it just takes them too long to get to a low enough level. For aminoglycosides, we do not redose until concentration post-dialysis has dropped below a certain concentration, referred to earlier slides. Often this means only redosing after every 2 to 4 dialysis. We typically do not schedule the redosing to be immediately after hemodialysis, but rather allow the aminoglycoside concentration to remain at trough concentration for another 4 to 6 hours before redosing. This way we hopefully minimize ototoxicity and take advantage of some post-antibiotic effect. Monitoring parameters for these drugs. We should be monitoring daily urine output when it's available. Unfortunately, this is rarely available for patients on the floor, but for patients in ICU, this should be available. For patients' creatinine monitoring, the frequency depends on the stability of the patient's renal function. Typically, 1 to 2 times a week is enough for a patient whose renal function is stable, but more frequent may be needed if the renal function is unstable or if the patient has risk factor for renal insufficiency, such as recent exposure or recipient of contrast dye, uncontrolled diabetes, concurrent nephrotoxins, or if they're critically ill with hemodynamic instability. Baseline auditory testing should be done if the patient will be on prolonged aminoglycoside therapy. This concludes today's session. Please do not hesitate to reach out to me for questions. For additional reading, please refer to your textbook.